There are two main factors influencing carbon dioxide levels in the blood. Number one, alveolar ventilation. Number two, dead space. Over the next few slides, we're going to talk about how both of these can impact our patients as well as arterial concentrations of CO2 in the blood. In order to best understand the relationship between alveolar ventilation and arterial levels of carbon dioxide in the blood, the best way to really go about it is to use an old friend of mine called the PaCO2 equation, which is your new friend. And before we get into this, what I'd like you to get out of this is the relationship between these three variables. You're not going to need to do any math. So let's dig in and define a couple of these. So PaCO2 is understandable. This is arterial concentration of CO2 in the blood. VCO2 is the CO2 production in the body. And if you think of the body as really a factory that is putting out, interesting factoid, about 200 milliliters of CO2 per minute, you can understand that for somebody who is resting in a healthy state, there is a steady state of CO2 production. In disease states, this is obviously going to be elevated, but for the purpose of these slides, really this is going to be a static number. And lastly, and most importantly, VA stands for alveolar ventilation, which is the primary means of excreting CO2 from the body. So now that we have that defined, I also want to pull in the law of mass action to understand the role of CO2 in acid-base disorders so we can have a broader conversation. So the law of mass action states that carbon dioxide joins with a water molecule via carbonic anhydrase to make carbonic acid. This carbonic acid then dissociates to bicarbonate and a hydrogen ion. So ultimately, let's choose a different color here. So these two things that I'm going to circle here are very important when we're talking about CO2. So putting this together, what we can see in the PaCO2 equation is a relationship of PaCO2 to alveolar ventilation. And if one increases the amount of alveolar ventilation, so increases the total minute volume, which we'll define in a second, if we increase the amount of ventilation, then overall we're going to blow off more CO2 and we are going to reduce the amount of CO2 in the blood. If we reduce alveolar ventilation, then this is going to increase the amount of PaCO2 in the blood. So let's see what it means when we increase or decrease the amount of PaCO2. So if we increase the amount of CO2 in the blood, what this does is this pushes the equation to the right and ultimately increases the amount of hydrogen ions in the body, creating a more acidic environment. So more carbon dioxide from less alveolar ventilation creates a respiratory acidosis. And respiratory acidosis, if it's respiratory, it specifically has to do with low alveolar ventilation. Low alveolar ventilation can come from a number of different reasons, or a number of different causes. Number one, CNS depression, as you would see in an opioid overdose. Neuromuscular disorders, like you would see in ALS, when the muscles themselves are unable to fire to allow us to breathe. Number three, chest wall issues like chest trauma or a pneumothorax, where a portion or the entirety of a lung is rendered inoperable. And lastly, a foreign body obstruction or an asthma exacerbation. So what happens when CO2 partial pressures of arterial CO2 reduce through more ventilation? Well, what happens is where there is less CO2, it actually pushes the entire equation to the left. pulling all of these hydrogen ions with it. Overall, this makes the body system more basic, and we say in the setting of high alveolar ventilation, we get a respiratory alkalosis, or kind of a more basic environment. Main causes of this can be CNS, or what we call supratentorial reasons, so things like fear, things like anxiety, which causes us to increase alveolar ventilation. We can have peripheral receptors get triggered via hypoxemic events. We can have pulmonary receptor stimulation through things like pulmonary edema, pneumonia, pulmonary embolism. This triggers our respiratory center to increase alveolar ventilation. And then lastly, we can have iatrogenic events, which means that a mechanical vent might be in a setting that is too high and we are blowing off too much CO2. So overall, in summary, the PaCO2 equation defines a relationship, an inverse relationship with alveolar ventilation. When PaCO2 rises in the blood, it sets off a cascade of events to try and compensate and rebalance the acid-base balance of the blood. Higher levels of PaCO2 will stimulate the respiratory centers of the medulla. This is the dorsal respiratory group and the ventral respiratory group, which we talked about in the anatomy lecture. Higher levels of CO2 in the blood cross the blood-brain barrier into the cerebral spinal fluid in the fourth ventricle here, and ultimately it's potassium which stimulates the respiratory center to increase respiratory rate. And this can happen on the order of seconds to minutes. So when I say increased respiratory rate, what I'm really talking about is an increase in minute respiratory volume. And minute respiratory volume, as documented here, is a combination of the tidal volume times the respiratory rate. So when this receptor here is triggered, it increases alveolar ventilation by increasing the rate and the depth of breathing. If the lung is otherwise disease-free, the minute respiratory volume, or again the amount of air inhaled and exhaled per minute, this will also increase the alveolar ventilation rate, which is represented here. And the AVR essentially is the minute respiratory volume minus dead space. So let's recall that tidal volume is approximately 500 milliliters. Dead space is approximately 150 milliliters of air, and the respiratory rate we can say is 12 times per minute in somebody that's resting. So the alveolar ventilation which is occurring is 300 milliliters of oxygen times 12 respirations per minute. So again, when that MRV is increased, we're not changing the dead space, but we are increasing the amount of tidal volume with depth of respiration, and we are also increasing the respiratory rate. So this ultimately will increase with rising PaCO2, as well as this will as well. Similarly with the peripheral chemoreceptors in the aortic and the carotid bodies, these will be triggered both by increasing PaCO2 as well as increasing hypoxia, or I should also write decreased PaO2. I'm kind of artificially separating out carbon dioxide and oxygen just to kind of make some specific points, but just be aware that the aortic body and the carotid body is exquisitely sensitive to hypoxia, which we will find in, which I'll be able to talk about in the following lecture. So what I'd like to do here is talk about the relationship between dead space, alveolar ventilation, and how this might impact PaCO2. So the alveolar ventilation rate, as we previously defined, was tidal volume minus dead space times the respiratory rate. And this really is something along the lines of 350 milliliters times whatever the respiratory rate is. This 350 milliliters is gas in the alveoli that is actively involved in gas exchange. So what happens when dead space is suddenly increased? When dead space is increased, this number is actually going to drop. And when this number drops, what this does is this elevates the PaCO2. So when the AVR is reduced with increased dead space, this creates a potential for a respiratory acidosis. And a respiratory acidosis doesn't always happen because the body can increase the amount of respiratory rate to compensate, but I would like you to understand that in some more devastating presentations of a massive pulmonary embolism, for example, a saddle embolus, the dead space in one's body can go from a normal amount of 150 milliliters to somewhere close to that of what the tidal volume is. So again, the relationship that I'd like you to understand is that dead space can impact one's ability to diffuse gases appropriately. And let's make a couple of definitions here when I'm talking about dead space. We've got anatomic dead space, which is the amount of air in the conducting zone. So this would be in the nose, the larynx, the trachea, etc., etc. So again, everything in this green color here. None of this is involved in gas exchange. Alveolar dead space, on the other hand, might be a focal portion of the lungs that are not able to be involved in gas exchange due to something like COPD or a pulmonary embolism or some issue with ventilation and perfusion. So again, anatomic dead space is conducting zone, which is standard in everybody, and alveolar dead space, this is the one that can really vacillate, can increase or decrease depending on one disease state. And lastly, when we put both of them together, anatomic plus alveolar dead space, we call this physiologic dead space. So in order to understand and kind of put into practice what we've just learned, let's talk about my friend Ignacio here. Ignacio just broke up with his girlfriend and is undergoing a massive anxiety attack. He can't fathom living his life without his partner, and now he's breathing heavily. As he increases his respiratory rate, what is going to happen to his PaCO2? Well, this is going to drop substantially, which is going to increase his pH and cause a respiratory alkalosis. And to put this into context, his minute respiratory volume is going to increase, and his alveolar ventilation rate is also going to increase because there is no issue with his dead space. This is purely psychogenic. This is what we call is supratentorial, which is just up above here. And the moment that he reduces his alveolar ventilation back to normal, his PaCO2 will follow. Now the following day, he decides to overdose on some old Norco that was in his bathroom from an old back injury. And unfortunately, this is more of a common story in the US than we think, but with an opioid overdose, what this will do is this will reduce his respiratory center, his respiratory drive to reduce his ventilation rate. And how this will impact his PaCO2 is to make it rise substantially. So his PaCO2 will rise as he is not ventilating his healthy alveoli, and this is going to reduce his pH. As his pH becomes more acidic, this is causing a primary respiratory acidosis. And to put this in context of the minute ventilation rate as well as the alveolar ventilation rate, both of these are going to go down. Now what I'd like to do is understand what happens when the alveoli themselves are affected by a disease. Let's understand how the clinical response of the patient is driven by a lot of the underlying physiology. So in the last two slides, we talked about the relationship between PaCO2 and alveolar ventilation, and it's this inverse relationship where if alveolar ventilation increases, PaCO2 will decrease and vice versa. We also talked about two methods of kind of measuring and understanding inhaling and exhaling air as well as air being used for gas exchange. The first is a volume, which is the minute respiratory volume, which is tidal volume times respiratory rate. The next is a volume in air used for gas exchange, which is really where you are looking at dead space. So in the two scenarios, which was anxiety as well as an overdose, neither one of these had to do with the lung. These had to do with reasons outside of the lung to increase or decrease alveolar ventilation. Now what I'd like to do is I would like to look at intrapulmonic reasons for changes in alveolar ventilation. So the first thing that I'm going to do is I am going to, these are the lungs of our friend Ignacio, is the first thing I'm going to do is I'm going to give him a big VQ deficit of a pulmonary embolism. And primarily what this causes is hypoxia. And let's kind of remind ourselves that the VQ deficit here is the ventilation is good, the alveoli are intact, but the capillary system is not able to transmit or perfuse blood to pick up gases for gas exchange. So without talking about the body's compensatory response, let's just look and see what happens to the alveolar ventilation rate. The main thing that happens here is that dead space increases. So if a normal amount of alveolar air used for gas exchange is 350 milliliters per breath, perhaps there's only 300 or perhaps there's only 250 milliliters used now that we have this large VQ deficit on his right lung. So again, if there's this large VQ deficit, there is a setup for PaCO2 potentially rising. Again, mainly because of this VQ deficit. Gases are not able to exchange. So this is the threat, and this is what the lung inherently understands through its receptors. Now, in terms of talking about receptors, we have central receptors, we have peripheral receptors. Those central receptors are triggered by increased in PaCO2, and peripheral receptors are triggered by hypoxia as well as rising PaCO2. But really it's this hypoxia that's the driving force. So when there is a sudden VQ mismatch, these receptors kick in to increase the amount of alveolar ventilation. I should write alveolar ventilation, excuse me. And it does so by increasing the MRV, essentially by increasing the depth, the rate and the depth of breathing. Tidal volume would be more than 500 milliliters, and respiratory rate would move from, say, 12 to 14 to 16 to 18 to 20 to even 30 to begin to compensate for losses in oxygen and too much CO2. So knowing all of this as a setup, there are two main scenarios that happen in a VQ deficit, a VQ mismatch. The first scenario, which is the most common, is that in a setting of a VQ mismatch, which has the threat of leading to an increased amount of PaCO2, the body will compensate so well that it'll wind up blowing off more carbon dioxide than is needed. So those central and peripheral chemoreceptors are overcompensating essentially. So what will happen is your body will wind up in a respiratory alkalosis, an acute respiratory alkalosis. So this is really common for somebody who initially presents with an asthma exacerbation or a PE or pneumonia. You will note that their respiration rate will be high. Their tidal volume will also be high as well. And despite a reduction in alveolar ventilation rate because of that new dead space, the body will compensate extremely well. So in acute VQ mismatch, most commonly one will see a respiratory alkalosis. Second scenario, which is less common. Again, an acute and perhaps even more severe VQ mismatch, like a massive PE, where a good portion of both lungs, for example, are taken offline. Despite all of the work that the body can put into increasing that respiratory rate and increasing that minute respiratory volume, the dead space is too much and too severe. So this will result in a respiratory acidosis. And again, this is more significant or more life-threatening. So this is a more severe cause. So again, just to summarize, the majority of VQ mismatches that you will see in the lung, any type of acute process that you see in the emergency room or the ICU, on an ABG, it's very common in an acute process to see a respiratory alkalosis. This means that the body's chemoreceptors are being triggered so substantially that the body is blowing off more CO2 than needed. And this response is more due to hypoxia than a CO2 problem. On the flip side, when the dead space is so severe or one is not able to compensate well for a severe intrapulmonary illness, you will see a worsening of alveolar ventilation and an increase in PaCO2 overall. And this will result in a respiratory acidosis. It's important to understand the dangers of hyper and hypocapnia. Let's go through them really quickly. Hypercapnia, we know, inherently has to do with an increase in PaCO2, which results in a respiratory acidosis. Indirectly, we know from the alveolar equation that this lowers the alveolar concentration of oxygen and can result in hypoxia. Common clinical symptoms that you will see will be disorientation, acute confusion, headache, mental obtundation, and in the most extreme examples will be coma. Hypocapnia, on the other hand, is due to a reduction in PaCO2 levels and causes a respiratory alkalosis. This has been seen to alter the balance of calcium and magnesium in the muscles, increasing the likelihood of tetany, spasm, weakness, and fatigue. In this slide, we're going to talk about the dangers of hypercapnia, and we're going to talk about it in relationship to a graph here on the right using two variables that we're already familiar with through the PCO2 equation. On the x-axis, we have alveolar ventilation, and on the y-axis, we have PaCO2 in millimeters of mercury. When we're talking about the dangers of hypercapnia, what we need to do is establish a baseline in a healthy individual. Alveolar ventilation for somebody who does not have any lung disease, is a non-smoker, is about 4 liters a minute. And this translates to about 40 millimeters of mercury of PCO2. Now let's give this patient COPD. Somebody with COPD is going to have a reduction in alveolar ventilation, and in this patient we can see that alveolar ventilation has been reduced from 4 liters a minute to 3 liters a minute because of an increase in dead space. And another way to think of this is there's just been a significant, reduction in real estate of functioning alveoli, a functioning lung. So this translates to 60 millimeters of mercury. We can see that this is a big step. This is going to impact the acid-base balance of a patient, and this is going to be a slow and insidious increase over a decade or so. Points to note about an increasing baseline of PaCo2 is that a higher arterial PaCo2, it lowers the alveolar oxygen concentration. Similarly, an increased arterial CO2 concentration, it lowers the pH or makes the patient more acidic. Now what we'll do is we are going to acutely increase the amount of dead space even more. It's supposed to be an arrow, by giving the patient pneumonia. And now we have reduced that real estate one more time, and how this impacts the PaCo2 on this curve is making it near, we'll say, 95 millimeters of mercury. This is a big deal. This is a huge and acute event. Instead of a chronic increase from a healthy state to a COPD state, we acutely have, over the course of days, an acute event which would result in acute respiratory acidosis because of an increased amount of dead space acutely. So if that baseline worsens acutely, this can cause a precipitous rise in dead space or VQ mismatching in the setting of an acute illness, and as we just discussed, can result in an acute respiratory acidosis.